Chapter 13 is about the spinal cord, spinal nerves, and the spinal reflexes. The spinal cord is located in the vertebral column, so this area is the vertebral column. If you remember it from chapter 7. So start here from foramen magnum, that is part of the occipital bone, and it goes around this area, which is L1, L2. So the function of the spinal cord is receiving sensory information. So that information that is coming from skin, from the joints and tendons and muscle, skeletal muscle, and that goes to the brain. Also the motor information that is sent from the brain, it passes through the spinal cord, and that goes to skeletal muscles. And there is also spinal reflexes, that is a combination of sensory and motor functions, and I will talk about that a little bit later. So here is the before I talk about the spinal cord itself, I can discuss a few different things about the anatomy of the vertebrae. So one is the vertebral body that is located anteriorly. Again, this is chapter 7, and this is the spinal process, which is located posteriorly. And this area, usually around this area, you have the transverse processes. It's not shown here properly. An area between the vertebral arch and vertebral body, this is the vertebral foramen, this area. So if you put multiple vertebrae on top of each other, or if you create multiple vertebral foramen on top of each other, then you will create a vertebral canal, and a spinal cord is located inside the vertebral canal. Also, if you put the vertebrae on top of each other, there is an area created in this area on the side, on each side, and that's called intervertebral foramen. Intervertebral foramen. So the content of intervertebral foramen is the spinal nerve in this area. So this is the spinal nerve. So the spine is covered by three different types of meninges. Meninges are connective tissues. So from deep to superficial, we start with this one that is called pia mater. Okay, this one, and that is attached to the spinal cord itself. Then you have this one that you can see, and this is called arachnoid mater. This one, the middle one, arachnoid. And there's a space here, and this is called the subarachnoid space. This dark area that you see between pia mater and arachnoid, this is called arachnoid space, subarachnoid space. And the content of that is CSF, cerebrospinal fluid. And I will come back to that in chapter 14 and talk about that in more detail. So the third meninges is this one. Okay, that's called Dura mater. So this one, the more superficial one. So this is the thickest one also. And there is a space here. There is one space between the dura and an arachnoid, and that is called the subdural space, subdural. And there is another one that is more superficial to the dura mater, and that is epidural space. So this one. So the content of the epidural space is usually blood vessels and fat. And the content of the subdural space is actually a potential space. So normally the dura and arachnoid, they are attached to each other, but there are some blood vessels can pass through this area. Also, you can see some other structures. One is called the denticulate ligament. So this ligament is attaching the spinal cord to the wall of the vertebral column or vertebral canal, so on each side, and that stabilizes the spinal cord, stabilizes the spinal cord. You can also see these ones, these are the nerve fibers. You can see that. So this is called the ventral root, which is located anteriorly, and this is the dorsal root, which is located posteriorly. And the dorsal root contains cell bodies, and this is called the dorsal root ganglion. So the combination of the ventral and dorsal root together, that makes the spinal nerve. Okay, and then they branches to the ventral ramus and the dorsal ramus. So ventral goes anteriorly and laterally, and dorsal ramus goes to the back. There is also this one. This is called sympathetic chain, but I will come back to that later in more detail, and I will show it to you what it does. Okay, so some specific structures in the spinal cord. One is called conus medullaris, which is around this area. So this is the end of the spinal cord. It has a shape like a cone. This is why it's called conus medullaris. Then it's called filum terminale, and this is from the tip of the conus medullaris goes all the way to the coccyx. This is made of pia mater, and again that stabilizes the spinal cord, so it does not move sideways that much. Then is the cauda equina. So these fibers that you see, these are the cauda equina. So the spinal cord ends in L1, L2, and after that these fibers that you see, these are the fibers that are the roots that will make eventually the spinal nerve. So here in the lumbar area and in the sacral area, these fibers are really long. You can see that they are very long because the spinal cord ends around this area. And the articulate ligament, which you cannot see it here, but I showed you in the previous image. So it's like ligaments like this. Okay, so these are connective tissue that connects the spinal cord to the wall of the vertebral canal. So this is the wall of the vertebral canal. This is the wall, so stabilizes the spinal cord. So there's a lot of anatomical structures here, so I put it in an animation kind of thing that you can see it one by one. So there's two different things that you can see, different areas that you can see in the spinal cord. So one is this white area, and these white areas there's three of them, so these are called white columns also. Okay, these ones, and this also you have this one which is a different color. So there's three of these white columns. One is called dorsal funiculus. So this is the dorsal funiculus. Then is the ventral funiculus. This one is located anteriorly, and the third one is called lateral funiculus. So there's three of them. Okay. There is also this different color that you see. This is called the gray matter. Okay. So the difference between the gray and white is that the gray matter contains cell bodies, and they may not be myelinated, but the white column is mostly myelinated. So there's a few structures in the gray matter. One is the gray commissure. So this is the area that is connecting the two gray matters on each side. Okay. They have these projections of the gray matter. So there is three of them. So you can have the dorsal horn located in the back, ventral horn anteriorly, and lateral horn, which is on the lateral side on each side. So you have three white columns, so one here, and one here, and you also have three horns, so one here, and one there, and there's a connection in the middle. This area that you can see, this is called the dorsal median sulcus. So it's a separation of the two sides of the spinal cord, and this is the ventral median fissure. So fissure is a little bit more open than the sulcus. And the central canal, which is a cavity, is a long cavity, and that contains CSF and located in the middle of the spinal cord. There is the spinal nerve, this thing that you see that I showed you before. This is the spinal nerve, and the spinal nerve is made of the dorsal root that contains the dorsal root ganglion. So this is the dorsal root ganglion, and also it's made of the ventral root. So these dorsal roots and ventral roots on each side If you can see, it is made of these ones, these smaller fibers. These are called the rootlets. Okay. And then there is three different meninges. So the deepest one is called the pia mater, that is attached to the spinal cord. The middle is called arachnoid, and the most superficial but the thickest one is called dura mater. So there is a space around the dura mater. So outside, that is called epidural. Between the dura and arachnoid, that is called subdural. And below the arachnoid, between the arachnoid and pia mater, is called the subarachnoid space. There is no other space deeper than pia mater. So there is no sub pia, there is no epipia space. So if you section the spinal cord, it looks like that. Okay. Going back to some of the structures that we talked about it before, one of them was the columns. So you have the lateral wide column, you have the dorsal wide column, and this is the ventral wide column. You also have these separations. So this is the anterior or ventral median fissure, and this is the dorsal median sulcus. Okay, or posterior median sulcus, same idea. And in the gray area, that you have the three horns there. So this is the ventral horn, this is lateral, and this is the dorsal horn. And here is the commissure. Commissure is the connection between right and left, and or between the two sides of the spinal cord. And in the middle, you have the central canal here. You also have a wide commissure here, a wide commissure. The fibers are passing from one side to another side. If you look at it, if I cut it the spinal cord like this, okay, so like halfway, it's not very exact half, but almost half. The anterior part is motor and the posterior part is sensory. Again, the motor and sensory divided into two parts. Okay, so the motor is divided into somatic, which means it's skeletal muscle, it goes to skeletal muscle, and visceral, that goes to the organs. For example, contraction of the intestine or the urinary bladder, things like that. Okay, and the sensory is also divided into two parts. One is the somatic one, that is more superficial, and that is the skin. Okay, and the visceral one, that is from the organs, and that is located deeper. This slide is about the white matter. So as I said before, white matter is made of fibers. Most of these fibers are myelinated, that's why it gives it a white color, but some of them may be non-myelinated. And these fibers may go up or may go down. If they are going up, they are ascending, and this is sensory fibers. And these, if they are going down, these are the motor ones, so descending. Some of them may cross the midline, so these are the areas of the commissures, and they are called transverse, transverse fibers. The white columns that I talked about it before, these are all called funiculi. So funiculi is the plural form, and funiculus is the singular form. Inside each white column, there is also something more specific that is called tract. So spinal tract is again, this is a fiber. Anatomically is not much different, but physiologically is different, because these tracts may go up or down, and they may have sensory or motor information. So inside one column, you may have different tracts that they may go up and down. Okay, so you may have multiple tracts inside one column. So let's talk about the tracts here. So you can see that it is divided into two different colors. In reality, it's not like that, but just for representation, you can see it like that. So ascending ones are the sensory, and descending ones are the motor ones. So let's talk about the sensory ones. This is the dorsal white column. So this area is the dorsal white column, and that's made of the fasciculus gracilis and fasciculus cuneatus. So fasciculus means tract, and gracilis is coming from lower extremity, and cuneatus is coming from upper extremity. And then is that you have a spinocerebellar. So from the spine it goes to cerebellum. So there's two of them. One is located more posteriorly, that's the dorsal one, and the other one is located more anteriorly, and that's the ventral one. And finally you have two other tracks here. So this is lateral spinothalamic. So from spine it goes to thalamus, and you have the ventral spinothalamic that goes from spinal cord to the thalamus, but they are located in two different directions, so carrying a little bit different information. They're all sensory, but they carry different information from different areas. An easy way to remember that if the spine starts in the beginning, it means this is ascending. Okay, so a spine starts from the beginning, so that is going upward. But look at the descending ones. Okay, so you have the, by the way, that the white commissure can have sensory or motor. The fibers are going both ways, and chapter 16 I will show you how they go these different tracts. So now is the motor one. So this is the reticulospinal tract. So reticular formation, that is in the lower part of the brain, it's called brainstem, and that goes to spinal cord. So if the spine is at the end, it means it is descending. So you have two reticulospinal tract. One is the lateral one, and there is also a medial one. This one is called the corticospinal tract. This is really important because it is the conscious motor activity belongs to this, but it goes to different parts of the body. That's why you have two of them. So this is the lateral one, and also you have the ventral one. So two different ones. And you also have some other ones that are subconscious. One is called the rubrospinal, the other one is vestibulospinal, and the other one is the tactospinal. So rubrospinal is from the midbrain, and vestibulospinal is from brainstem, and tactospinal is again from midbrain. So spine, if you can see it here, is at the end, so it means that they are descending. So it's an easy way to remember it. There is a lot more information about this, and it will be discussed in more detail in chapter 16. Now is about the nerve fibers. So if you can look at it, this whole thing is a nerve, and the whole nerve is covered by a type of connective tissue, and that is called the epineurium. So similar to epimegium that you had in the muscle, same idea here. One nerve is made of multiple smaller compartments, and these are called fascicles, and each fascicle is covered by a type of connective tissue, and that is perineurium. And then is that one muscle fascicle is made of multiple nerve fibers, and each nerve fiber is covered by a type of connective tissue, and that is the endoneurium. So then inside that you may have the Schwann cell. Okay, I mean, you may or may not have Schwann cell, depends if it is myelinated or unmyelinated, but you will have the axon here in the middle. And you can also see that some of them are thicker and some of them are thinner. That depends on how fast they can send information, and that type of innervation varies from one area of the body to another area. So for example, skeletal muscle, they have thicker nerves, and sensory information from the visceral organs, they have thinner fibers. So it's a little bit different in each area. Okay, so this image looks a little bit complicated, but it is not that complicated. So the important thing to know is that initially you have to know the anatomy of spinal cord here, because if you don't know the anatomy, then the direction will be very difficult to know. So let me go back and review the anatomy very quickly. Okay, so these are the three white columns, and this is the gray area, and the gray area you can see that this is the posterior column, this is the lateral, the posterior horn, this is the lateral horn, and this is the ventral horn. So you have these one, this is the one root and this is another root. So this is the ventral root and this is the dorsal root. And if you think, okay, how would I know the difference? this one, dorsal root ganglion, which is a collection of cell bodies outside of the CNS. So the dorsal root ganglion is located in the dorsal root. Then they combine together, and that makes the spinal nerve. This area is the spinal nerve, and then they divide again to the ramus. So there's two rami are there. Okay, one is the dorsal ramus, and the other one is the ventral ramus. And you also see something else here. This is called the sympathetic chain. So this is the sympathetic chain is made of the rami communicantes and sympathetic ganglia. So that is running on the side or parallel to the spinal cord. So if you did not understand this, please go back and listen to this part of the lecture again and again before listening to the rest of it. Okay. Now let's look at these fibers that are going in different directions. So look at here. This is the ventral root. Ventral root contains motor information. Okay, ventral root contains motor information. Ventral or anterior horn and lateral horn, they both contains motor information. Different type of motor information, but still motor. So let's look at one by one. Okay, so starting with the anterior horn that contains somatic, which means it goes to the muscle. So the cell body is located here, and the ventral horn leaves the spinal cord that goes through the ventral root. It goes to the spinal nerve, and now that becomes to the ramus. So it may go to the ventral ramus, and that goes to the skeletal muscles of the body wall and limbs, or it may go to the back through the dorsal ramus. So that goes to the back muscles that are conscious. So this is we are talking about the skeletal muscle, which is conscious. So this is not difficult. Okay, now this one is a little bit more complicated, the visceral motor. So the cell body is located in the lateral horn, and it leaves the spinal cord. It goes through the ventral root. It goes to the spinal nerve, but now it goes to the sympathetic chain. Initially, it goes through the rami communicantes, and you can see there's two different parts here. This is called the white ramus. Why is white ramus? Because this is myelinated. Okay, this is myelinated. So it goes here and it makes a synapse in the sympathetic ganglion. Now you have another neuron that is not myelinated. It leaves the sympathetic ganglion. It goes through the sympathetic nerve, and it goes to the chest, and that will supply smooth muscles, glands, visceral organs, for example lungs, esophagus, trachea, and it may supply blood vessels, fat, and things like that. So now is another one. Okay, so starting again from the lateral horn, so the cell bodies are there. It goes through the ventral root, it goes to the spinal nerve, it goes to the white ramus of rami communicantes. Now it does not synapse here. It does not. So this is myelinated. It goes all the way. It passes through the sympathetic ganglion, does not synapse there. It goes through the sympathetic nerve, and finally it gets to the abdomen. So that supplies the abdominal pelvic organs. Okay. The third one is another one. Okay, so there's another visceral motor nuclei that is located here. So cell body is there. It leaves the spinal cord, and it goes to the ventral root. It goes to the spinal nerve, and now it comes through the white ramus of rami communicantes. It synapses in the sympathetic ganglion. It doesn't go through the sympathetic nerve. Okay, now is that unmyelinated fiber. It goes back to the rami communicantes. This is the gray ramus of rami communicantes, which means this is unmyelinated. It goes back to the spinal nerve, and then it splits. Some of them goes to the ventral ramus of rami communicantes, so that goes to the smooth muscles, glands, adipose tissue of the body walls and limbs. And the other one is going in the back. So same idea, but this goes through the dorsal ramus of the rami communicantes. So same idea here. This is a sensory. The previous one was motor. This is sensory. How do I know it's a sensory? It is simple. Why? Because now the dorsal root is involved here. Okay, so if you remember chapter 12, for sensory you need receptors. There were three different types of receptors that were processing different type of information. So you had exteroceptors, which was for example for light touch and light pressure, and also for temperature. You had the proprioceptors, which was for movement of the joints and also the stretch of the muscles, things like that. And interoceptors, they were, for example, they were for pain and deep pressure. So these receptors are located in the body walls and limbs, and these are the dendrites, and then the fibers are going toward the spinal cord. So then it enters through the ventral ramus, and it goes through the spinal nerve, and then it goes to the ventral root. So now the cell body is located in the dorsal root ganglion. For example, the dendrite can be in your big toe, but the cell body of the same neuron is located near the spinal cord. So it's that far. And these are unipolar or pseudo-unipolar neurons. And then the fibers again continues, and that goes to the dorsal horn of the spinal cord, which is, if you remember, dorsal horn is sensory. Same type of information, but from a different area, which is the back, are coming from the dorsal ramus that goes to the spinal nerve, and then it goes to the spinal root. Same idea here, and the cell body is located there in the dorsal root ganglion, and it arrives there, and processed in the dorsal horn. So these are conscious. Okay, these are the conscious information. Some of them may be subconscious also. For example, the changes that is happening in the visceral organs, and if they are happening there, then they are interoceptors. So in the visceral organs, you do not have proprioceptors or exteroceptors. So these interoceptors, so for example, distension of an organ, changing in the blood pressure, things like that. That information is going toward the sympathetic chain ganglion. So these nerves are going there, passes through the rami communicantes, enters the spinal nerve, goes through the dorsal root. The cell body is located there, and then it reaches the deeper part of the dorsal horn of the spinal cord, and from there it goes to the brain. So now the spinal nerves. Okay, so you have 31 pairs, so 31 on each side, and then it supplies most of the body. There are some areas of the body that is not supplied by spinal nerves, is the face, part of the neck, part of the head, but the other parts of the body is supplied by the spinal nerves. The spinal cord is divided into 5 different parts. One is the cervical area, and that is C1 to C8. So you have 8 nerves there. Then the thoracic area, and these are from T1 to T12. So you have 12 of them. Lumbar, you have there's 5 of them are there, and sacral, which is again 5 of them, and coccygeal, which is only 1 of them. And usually you can see it here. This is end of the spinal cord, so it's L1, L2. This is conus medullaris, and as you can see, this is the cauda equina, and these nerve fibers are getting longer and longer and longer as they are trying to exit or trying to enter the spinal cord, they are getting longer and longer and longer because the spinal cord ends around this area. So what about rami? The ventral ramis, okay, so remember this is important. Ventral ramis, they create a network of nerves, and these are called plexuses. Ventral ramis creating a network of nerves, and they are called plexuses. There's 4 of them: cervical, brachial, lumbar, and sacral. But those ventral rami between T2 to T12 do not make any plexuses. Do not. Okay. What they make, they are making intercostal nerves. So these intercostal nerves are supplying the anterior and lateral part of the chest and the abdomen. So both sensory and motor. What happens in the dorsal rami? The dorsal rami are not making any plexuses. They are not making anything. Okay. They are supplying the skin and the muscles of the back. The dorsal rami are supplying the skin and the muscles of the back. So this cervical, these plexuses are actually the hardest part of this chapter. Okay, so I recommend you to study each plexus separately. Don't study all of them together because it will be difficult to remember everything. Okay, so the nerves of the cervical plexus is between C2 and C5. Okay, there is a small branch of the C1 is also involved, but mostly is between C2 and C4. C5 is a little bit involved also. The cervical plexus is divided into sensory and motor. So a majority of them are sensory, but there are 2 important motor nerves also there. So let's start with the first one. This is called greater auricular. So this is the external acoustic meatus, and it's supplying that area around the ear. Okay, so the posterior aspect of the ear and the neck area supplied by greater auricular. Then you have the lesser occipital. So the lesser occipital is just the back of the upper neck, so near the occipital area, and also this area. So a little bit of the ear is supplied, so superior of the ear. So this area is supplied by lesser occipital. Then you have the transverse cervical, so which is this nerve, and this is supplying the anterior triangle of the neck. So what is the anterior triangle? So if you draw a line here in the midline, something like this, okay, then you have the sternocleidomastoid muscle, which is this area. It's not shown here, but it's this area, and then is the lower part of the mandible. So that is making the anterior triangle of the neck, and this nerve is supplying the skin sensory of that area. Another sensory is called supraclavicular. So this is above the clavicle. So this is the clavicle, and this is the supraclavicular, and that's supplying the posterior lateral side of the neck and upper part of the shoulder. So this area, around this area, is supplied by this nerve. So it's called posterior triangle of the neck. Okay. Then is the 2 motor. Okay, one is called ansa cervicalis, and these are the muscles that are supplied by ansa cervicalis. This is the geniohyoid, so from the back of the genio of the mandible all the way to hyoid bone. This is omohyoid, and this is the sternohyoid, this is the thyrohyoid, and sternothyroid. So there is a few muscles that are supplied by ansa cervicalis. The one that is important one is called the phrenic nerve. This is the most important nerve in the cervical plexus because this one is supplying the diaphragm, and this is the diaphragm is a primary inspiratory muscle, so which means it's important for breathing. If both the diaphragm are paralyzed, the person cannot breathe, the person will not survive. So that's that important. This is the brachial plexus, so this is the most difficult one among all the plexuses. So let me start from this area. Okay, so it says ventral rami roots. So remember that the two roots combine together, and that makes the spinal nerve, and then the spinal nerve divides again to the ventral root and the dorsal root. I mean the ventral ramus and the dorsal ramus. Ventral ramus and dorsal ramus. The dorsal ramus goes to the back, does not do anything, it's not creating any plexus, so we shouldn't bother about it for now. The ventral one is the one that makes the plexus. Okay, so this is why it's a little bit confusing. It says ventral rami roots. So the ventral rami is the one that is coming from the spinal cord, and this area is called just roots. So this is not the same roots that was coming directly from the spinal cord or going directly to the spinal cord, because that is inside the vertebral column. Okay, so the naming is a little bit confusing. So the brachial plexus is made of C5 to T1. Okay, ventral rami, and so C1 and C5 and C6 join together, and that makes the superior trunk. C7 continues as middle trunk. C8 T1 fuses together, and that makes the inferior trunk. Then the trunks will divide into divisions. So there's two divisions. One is anterior division, the other one is the posterior division. So this, and this one. Okay, these three are the anterior division. This one, and this one is the posterior division. Then it divides into chords. Okay, so you have three different chords. You have the lateral chord, you have the medial chord, and you have the posterior chord. So there's three different ones. And then you have the spinal smaller nerves there. So a lot of spinal nerves. These are all spinal nerves, but there are smaller ones. Okay. So this one is called dorsal scapular, and that supplies a rhomboid, minor and major, and levator scapulae muscles. This one is called the subclavius nerve, and that's supplying the subclavius muscle. This is the suprascapular nerve, and that's supplying the supraspinatus and infraspinatus and part of the shoulder joint. This one that you see, this is called the long thoracic. It's not written there. That is for the serratus anterior. Serratus anterior. And this area is for the pectoralis nerve, so for pectoralis major and pectoralis minor. So you can see this area. And also this one is called the subscapular nerve, and that is for subscapularis and teres major. And this one is called the thoracodorsal nerve, and that is for latissimus dorsi muscle. This is the axillary nerve, which is for the deltoid and teres minor. And this one is the musculocutaneous, which I will talk about it in the next slide. And then here you can see that the medial and lateral cords combine and then makes the median nerve. The posterior cord continues as the radial nerve, and the part of the medial cord continues as the ulnar nerve. You also have two other nerves here. This is called medial antebrachial cutaneous nerve, that supplies the medial part of the forearm, and this one that is not written there is called medial brachial cutaneous nerve, which is supplying the medial part of the arm. Okay, and another there's a small mistake here. This is not with I, this is with E, so please fix that. Okay, with E, not with I. And now the rest of the brachial plexus, as you can see, the brachial plexus is supplying the upper arm here. Okay, and upper I mean the upper limb, not upper arm, so upper limb. So it's supplying the arm, forearm, and the hands. So here let's talk about each one separately. So this is the axillary nerve that I discussed it before. So this is the deltoid muscle, and the teres minor is around here, and also supplies the skin of this area. And this is the radial nerve. So this is from the posterior cord that you can see. It's going like this and goes all the way like this, all the way. So it's a little bit hard to see this because it's the 2D image, so it's a little bit difficult to think about it. But the radial nerve is easy to remember. Is supplying the muscles of the posterior arm, the muscles of the posterior forearm, and also some of the muscles of the back of the hand. Also it supplies the skin of the arm, the skin of the forearm, and this is all posterior part, okay? And also 3.5 fingers of the posterior part of the hand, 3.5 fingers laterally. So once again, the radial nerve is supplying both skin and motor of posterior part of the upper limb. But when it gets to the hand, it's not supplying everything. It is supplying 3.5 fingers laterally. It goes all like this, all the way, supplying up to here. So the medial part is supplied by the different nerve. Then is the musculocutaneous nerve, and this muscle comes here, and that supplies the muscles that cause flexion of the elbow, for example, coracobrachialis and biceps brachii, and also brachialis muscle. So coracobrachialis cause adduction of the shoulder also, and cause flexion of the shoulder. So biceps brachii and brachialis cause flexion of the elbow, and coracobrachialis cause flexion and adduction of the shoulder. So it's affecting both joints, but musculocutaneous is mainly for elbow, flexion of the elbow. Also it supplies the skin of the lateral part of the forearm. Then is the median nerve that is located more anteriorly, and that supplies the muscles of the forearm, which is affecting the wrist and the hand and the fingers. So that's important for the flexion of the wrist and fingers. Also for the skin, it is supplying 3.5 fingers laterally. This is anteriorly, okay? So radial nerve is supplying 3.5 fingers posteriorly, median nerve 3.5 fingers anteriorly, and both of them are on the lateral side of the hand, okay? Lateral side. The ulnar nerve is supplying a couple of muscles on the forearm area, so that's important for flexion of the wrist and fingers, but also supplying 1.5 fingers medially. 1.5 fingers medially, both anterior and posterior part of the hand. Anterior and posterior part of the hand, but 1.5 fingers medially. This is the lumbar plexus, so between L1 and L4. So you have a few different nerves here. One is called iliohypogastric. So this has sensory and motor. The motor of this nerve is similar to ilioinguinal. So it's supplying transversus abdominis and internal oblique muscles. So this area. So the motor function is the same between these two nerves. The sensory of iliohypogastric is that it is supplying the suprapubic area, which is this area, and also this area, which is the lateral gluteal, so which is this area. So from here to here is supplying the skin of that area. The ilioinguinal and genitofemoral sensory is the same, okay? Look at the name. So genitofemoral, so supplying the genitalia and also femoral area, which is this part of the thigh. Femoral is the whole area. This area is called femur, but this is the upper medial thigh. Okay, so that's supplying this area and also the genitalia. So both of these two nerves, sensory innervation is the same. Motor innervation of ilioinguinal is the same as iliohypogastric. Genitofemoral also cause motor, cause innervation of the motor muscles of cremaster. This is mainly in male, and let's not talk about it for now because you have to know some other functions in male genitalia, and that's not part of this chapter, so let's leave it for ANP2. Femoral nerve is a big nerve, so this is the biggest nerve in the lumbar plexus, and that is supplying the quadriceps muscles. Okay, so quadriceps muscles, if you remember, cause extension of the knee, also cause iliopsoas muscles, so supplying iliopsoas that can cause flexion of the hip and also cause flexion of the lumbar area, and sartorius, if you remember the sartorius muscle, which is running oblique, and that's also cause flexion of the hip and the knee. It also supplies the sensory skin area of anterior thigh, medial thigh, and medial leg all the way to the medial foot. Okay, so like this medially, but for the thigh area is also supplying anterior part of it. Lateral femoral cutaneous nerve, this is only sensory, and that is, the name is very obvious, so it supplies the lateral part of the thigh. And obturator nerve, this is supplying adductor muscle, so cause adductor muscle. Gracilis is also an adductor muscle, and that is called adduction of the hip. And sensory is similar to ilioinguinal and genitofemoral, which is supplying the upper medial thigh. Sacral plexus is L4 to S3, or S4 actually, L4 to S4, and it has a few different nerves. One is called superior gluteal, and that's supplying all gluteal muscles except the gluteus maximus, which is supplied by the inferior gluteal nerve. The pudendal nerve is supplying the pelvic floor muscles and also the skin of the pelvis, which is part of the genitalia and anal area. Posterior femoral cutaneous nerve, so that is supplying the back of the thigh. This is sensory only. The sciatic nerve, this is the biggest nerve in the body, okay, that runs posteriorly, and then it divides into two different nerves, so that the tibial nerve and the common fibular nerve. The common fibular nerve has sensory and motor, and also tibial has sensory and motor. So the common fibular is supplying the anterior and lateral leg muscles, and also a little bit of the dorsal foot muscles. Also it supplies the skin of the anterior leg and the dorsal foot. The tibial nerve, it is supplying the muscles of the back of the leg, and also the muscles that are located in the plantar surface of the foot. The skin is the lateral and also the dorsal or posterior part of the leg and the plantar surface of the foot. Sciatic nerve also supplies quadriceps muscles in the thigh, which cause flexion of the knee. So this is the summary of these plexuses. I will not go over it, so all the information is summarized here, so you can see this is the motor innervation, so you can see half anterior, half posterior, and you have all these four plexuses here, and this is the sensory of these four plexuses, anterior and posterior. So if you want to memorize, you can look at this slide first, try to memorize everything, then you go back to those other slides, and if that makes your life easier. Or once you finish with those four plexuses, come back here and review all of them, and that way it will give you a bigger picture of all the nerves in one slide. Different topic is called neuronal pools, and these are neurons that are connected to each other, and these are interneurons. Some of them are increasing information, some of them are decreasing information. So it just helps process different type of information. So there is different types of neurons in the neuronal pools. One is called divergence. Here the one neuron is connected to multiple other neurons, so here the information increases. So an example of this, it can be in the sensory system. So information goes from skin to spinal cord, and when it goes to the brain, it goes to different parts of the brain, so the information process actually increase. Convergence is that multiple neurons connect to a fewer neurons, so here the information decrease. Example is in the motor system, that motor information or signals are coming from the cortex of the brain and also from brain stem and other cerebellum, and there's so many different parts of the bodies. I mean the different parts of the central nervous system is involved there, but when it goes to a few muscles, so it decreases. The information is converged. Serial processing, the information neither decrease or increase. Same information is sent from one neuron to another neuron. That you can see it in some of the tracts in the spinal cord. Then is the parallel processing here, that you have first the divergence and then you have the serial processing. So information here is increased, and again you can see this in some of the pain pathways in the brain. The last one is called reverberation, that you have one neuron and that neuron is stimulating the second neuron, and the second neuron is going back and is stimulating the first neuron and also sends information to the third neuron. So this is also stimulated. So, and a good example of that is breathing, and another example is sleep. Okay, so it continuously doing a specific function. Reflexes, these are automatic responses. Most of them are in the spinal cord, but some of them are in the cranial nerves also. They are doing activities that you don't have to think about it, so it will reduce the function of the cortex of the brain, so the cortex of the brain can be involved in more complex activities. Or when you learn something, that becomes a reflex, so you don't have to think about it and you can just do that activity. Sometimes these reflexes are designed to reduce harm to the body, so removing a specific part of the body from harmful stimuli. So there is different examples of that, and usually it works as a negative feedback. You have here a reflex arc there, that you have to have at least one sensory neuron and at least one motor neuron. You may also have interneurons that are connecting these two, and you have some other neurons that may go to the brain, and then you become consciously aware of the stimulus. So this is the classification of the reflexes. One is based on development. Some of them are innate. It means that the person is born with it. An example of that is that, for example, breathing is a reflex, or changing the blood pressure, it can be reflex. Or when the baby is born, the first hour the baby starts suckling a mother's breast. Nobody taught the baby or the newborn how to suckle the breast, and it is there. It's already a reflex there. And acquired reflex are that you learn later on. For example, you walk, for example you swim, you drive. All those things become later on. You learn those activities, and that become a reflex. Then is on the type of response. One is the somatic one. This is the conscious one, so it is skin and the skeletal muscle is involved there. And the visceral ones that are subconscious, so changing in the heart rate changing, and the secretions of the glands, respiratory rate, and blood pressure. All those things are related to the visceral reflexes. And how many neurons are there? So if it is two neurons are there, it's only one synapse, that's called the monosynaptic. Or if there are more than two neurons, that's called polysynaptic. And monosynaptics are a lot faster than polysynaptic ones. And the location that the information is processed, one is called spinal reflexes because they are located in the spinal cord, and the other one is cranial reflexes, which is processed in the brain. So let's talk about these reflexes separately. So the monosynaptic ones, you have to have one sensory and one motor, and that's why it is very fast. An example of that is called postural reflex. And here, for example, when you're sitting and when you're standing, these back muscles are contracting, and that's keeping your head, neck, and also posture properly. Also, the leg muscles and the thigh muscles are contracting, and that's why you do not fall. So if these reflexes are not working properly, then the person can have a posture like that, and that may cause back pain and neck pain and some other problems. Another example is the stretch reflex, and here for the stretch reflex it's better to talk about the muscle spindle first. Okay, so this is inside the muscle, inside the skeletal muscle. Most of the skeletal muscle is made of these fibers. These are called extrafusal. These are the muscle fibers that cause contraction of a muscle. But you may also have something else, and these are called intrafusal fibers. And the intrafusal fibers are connected to the nerves, and those nerves go to the central nervous system. So once a muscle is stretched like this, see that the muscle is stretched already, and you are hitting it with a reflex hammer, and that is hitting the tendon, so increasing the stretching of the muscle. So this intrafusal fibers are activated. The signals are sent to the brain, I mean to the spinal cord, not to the brain, to the spinal cord, and then it comes back from the spinal cord here to the intrafusal fibers, and that causes contraction of the intrafusal fibers, and also other nerves come here. It's not shown here properly. That will cause contraction of the extrafusal fibers. So when it's stretched too much, these muscles contract, and then this is the response. So the person is kicking. So here is, if you look at this area, this is the intrafusal one. So this is areas that is now stretched too much, and that's sending a sensory signal. And the cell body is located in the dorsal root ganglion. Now it goes to the posterior horn, and here is there's synapse together. So there is only one synapse, and the motor neuron, which is located in the anterior horn of the spinal cord, then it leaves through the ventral root, and that will cause contraction of the extrafusal fibers, and that will cause contraction, and the person kicks. Okay. Another one is called polysynaptic ones. It means that there is more than one synapses there, so multiple neurons are there. And a good example is called the tendon reflex. So here is the tendon here. Tendon is an area that a muscle connects to the bone. So when you are contracting a muscle, you are putting a lot of pressure on the tendon. So if this is too much pressure on the tendon, then a reflex is activated. For example, you are lifting something that is very, very heavy. There's too much pressure there, and sensory signals are sent to the spinal cord, and this is the cell body outside of CNS, and sensory information goes to the dorsal horn, and you have the interneurons here, and then it connects with the motor neuron. So here the motor neuron is inhibiting the contraction of this muscle, so reducing the damage and the pressure or tear in the tendon, and the opposite muscles are activated here, and now the person, instead of contracting or flexing the elbow, the person can extend the elbow, and then the weight will fall from your hands. So that is the main reason for that, is to prevent damage to the tendon. This is another example that's called withdrawal reflex. So here, if you're touching something really hot, or maybe something painful or sharp or something, then what happens here, sensory signals are sent to the spinal cord here. This is the posterior horn of the spinal cord that processes sensory information. You have an interneuron here, and that's connected to the motor neuron in the anterior horn of the spinal cord. And then the information goes through the ventral root, goes to the muscle, cause contraction of the biceps muscle, for example, and that will cause a flexion of the elbow, and then you are removing your hand from the painful stimulus, and that is a negative feedback, so it's preventing damage to a specific part of the body. And at the same time, it's inhibiting the opposite muscles. So if the triceps muscles were contracting here, in this case the elbow would have been extended, and then it would cause more damage. That's why this is inhibited. And as you can see here, the information is sent to the brain because you become consciously aware of that. But usually by the time you become consciously aware and you feel the pain, your hand is already removed from that area. It's very, very fast because it's more localized. When the time goes to the information goes to the brain, it takes time. But this is happening in the spinal cord, so it's a lot faster. And another example is called cross extensor reflex. Okay, so for that, let's talk about this leg first. This leg is extended, the knee is extended here, and you're putting your foot on something painful, and now you want to remove your foot because that's painful. So the information is sent to the spinal cord, same idea there. So the posterior horn is processing that, and this is an interneuron that goes here in the anterior horn of the spinal cord here, and now the flexor muscles are stimulated. So these the hamstring muscles cause flexion of the knee and inhibition of the quadriceps muscle. So that's why your knee is flexed here, and you are removing your foot from the painful stimulus. So this is still the withdrawal reflex, like similar to this one, but something else is happening here. The information is also connected with the opposite side. So now what happens here, on the opposite side, the quadriceps muscles are stimulated. That will cause extension of the knee, and hamstring muscles are inhibited, so that's an inhibiting flexion of the knee. So this is why it keeps your balance. So the opposite leg is, or the opposite limb is extended, and it's keeping your balance. Otherwise, if both of them contract, you may fall. So this is why it's called cross extensor. So it's going to the opposite side. You see that? It goes to the opposite side. But again, it will go to the brain because the information is processed there, and you can feel the pain in the specific area. By the way, this is the automatic reflexes. Automatic reflexes are happening in the brain, and initially when you try to learn something, for example walking or running or jumping, the brain will think about it, that which muscle should contract. As you do that more and more and more, then that is saved in the memory and a specific part of the brain, which I will talk about it later, and that becomes a reflex. So then the brain does not have to think about those reflexes. These are specific movements, and they can think about more complicated problems that are there. So the more you do an activity, you will increase the reflex against that. But the brain can inhibit a reflex. So consciously you can inhibit a reflex. And there is also Babinski reflexes there. So what happens that if it is an infant, so less than 1 year old, and you have a reflex hammer, so starting from the heel and go toward the toe, usually um, the baby or the infant will cause extension of the toes here. Okay, extension. But a normal person, more than age 1, it will cause flexion. So you see this a lot more than this one. So if you are over, if the patient is over 1, then the Babinski reflex causes flexion of the toes. Younger than 1, it causes extension of the toes. But if there has been damage, okay, in the motor tracts, in the spinal cord or higher, this will cause this reflex. Okay, so it can cause extension of the toes, which is not normal. So anybody above age 1 should not have extension of the toe with the Babinski reflex. Should have this. Sometimes you may not have this reflex at all, and that's still normal. 20% of people may not have reflexes. But if you have it and it will cause extension, it may be a problem with the motor pathways. Thank you.